Hi everyone, thank you for joining this third event of the Bordering series. Today we're going to discuss the multiple jeopardy of gender-based violence, migration and COVID-19. This is a collaboration between two centers within the Institute of Global Health in UCL, the Center for the Health of Women, Children and Adolescents and the Gender and Health Center, the Migration Research Unit, also in UCL, and Lancet Migration. My name is Dilan Devakumar. I'm an associate professor in UCL in the Institute for Global Health. I work primarily on child and adolescent health, and I was one of the leads of Lancet Commission on Migration and Health. And I'm currently the child and adolescent health lead in Lancet Migration. I also work on gender-based violence, primarily in South Asia, and on COVID-19, mostly on child health, and on issues of racism and xenophobia. Today, we've got four fantastic speakers, Professor Terry McGovern, Dr. Ligia Kiss, Dr. Ines Kenayard, and Mr. Joseph Bartovich. I will introduce each speaker properly before they speak. In terms of COVID-19, the pandemic has exposed many flaws in society that lead to ill health. One of the main concerns is this potential for an increase in gender-based violence that many people have reported and many services are reporting. This can be due to a number of factors such as financial or food insecurity, close proximity to perpetrators, lack of services, isolation, breakdown of social networks, and all of these can be exacerbated by the process of migration. Migrants, for example, may not have access to violence health services, may live in precarious conditions, and may, of course, be at increased risk of COVID-19 itself. Today, we'll discuss how COVID and migration can increase the risk of gender-based violence. And are the policies gender responsive, or are some people being left behind? The format for today will be each person will speak and present briefly, and then there'll be one question pre-prepared, and then we'll go through the four talks, and then there'll be set questions followed by questions from anyone in the audience. Please do add your questions to the Q&A function, and we'll pick them up as we go along. So first to our first speaker, Professor Terry McGovern. Terry was part of our Lancet Commission on Migration and Health. Terry is a professor and chair of the Hartbrunn Department of Population and Family Health at Columbia University, Columbia Mailman School of Public Health. Her research focuses on health and human rights, sexual and reproductive rights and health, gender justice and environmental justice. Terry founded the HIV Law Project in 1989, where she served as its executive director for 10 years. She successfully litigated numerous cases against the federal, state, and local governments, including which forced the Social Security Administration to expand HIV-related disability criteria so that women and other excluded individuals can qualify for Medicaid and Social Security. From 2006 until 2012, she was the Senior Program Officer in Gender Rights and Equality Unit of the Ford Foundation. And she recently co-edited The Women and Girls Rising, Rights, Progress and Resistance, a global anthology. Terry, over to you. Thank you.
Okay, thank you so much. You can tell that I'm not young, given that long list of things. Thank you so much to UCL. It's really a pleasure to be here with such great colleagues. My screen sharing function is not working, so I'm going to be reliant on UCL to share my slides. So can we bring them up? Okay. So the triple burden, let's go to the next slide, please. So you all know this, you can look at it. Migrants face unique vulnerabilities when it comes to gender-based violence, even in normal times. Disruption of social support networks and communities, changed gender norms, family dynamics, limited privacy, reduced food and economic opportunity. Health and migration are also highly gendered, affecting women, men, and sexual minorities quite differently in humanitarian settings. Implementing agencies often apply host country laws, which can or cannot sustain or foster health inequalities by gender, i.e., can unmarried adolescents access services, et cetera, et cetera. International standards are often ignored. Gender-based violence before, during, and after migration is often unseen and underreported. And of course, you know that a meta-analysis of studies in humanitarian settings suggested 21% of female refugees or displaced women in complex humanitarian emergencies experience sexual violence. And this is probably an underestimation. So of course, the epidemic has exacerbated these vulnerabilities and created new ones. The countermeasures for COVID-19 have increased risk factors. There's lots of reports from organizations that respond to gender-based violence that reveal an alarming picture of increased reports of gender-based violence, as well as reduced capacity to respond. Obviously, with people spending more time at home or wherever they are, coping with additional stresses, school closures, increased care, financial hardship, women are at risk of experiencing higher levels of violence. So are children. Many men and women are in informal economies, and mobility restrictions coupled with this economic slowdown have eliminated this source of income. So for example, in Jordan, there's been a 68% reduction in gender-based violence cases reported, with people there saying the decrease is not due to a drop in cases, but there's increased barriers on reporting. Legal aid and service centers are often not operating and are not exempt often from closure as essential services. In a number of refugee hosting countries, Greece, Lebanon, discriminatory movement restrictions have been placed on refugees, making it very, very difficult for women to leave and report cases or get necessary medical and legal services. Of course, there's the reduced government and NGO presence in conflict zones, which allow, in some cases, armed groups, non-state actors to implement their own pandemic restrictions, creating new gender-based violence risks. In Colombia, for example, armed groups use the threat of violence to impose pandemic restrictions in at least 9 of Colombia's 32 states. Climate refugees, those forced to leave due to a sudden environmental impact, are among the most impacted, and they of course lack any protection under international law. Our Global Health Justice and Governance Group conducted a rapid assessment of the impact of COVID-19 on the availability, use, and funding for GBV and sexual reproductive health services in Colombia, Kenya, Nigeria, South Africa, Uganda, and the US. We conducted 148 interviews. Overall, the findings reveal an increase in gender-based violence, with migrants absolutely among the most vulnerable populations, consistently blocked from accessing essential GBV and sexual and reproductive health services. In Uganda's Yumbe, the largest population of South Sudanese refugees, there was a 50% increase in sexual and gender-based violence, and messages targeted to family planning and sexual and reproductive health were often not in languages accessible. And of course, there was a huge decline in remittances that kept coming up. In Colombia, Venezuelan migrant women were among the most impacted. They faced extensive discrimination and problems accessing sexual and reproductive health and GBV services. They had great fear due to no documentation. In South Africa, we found, again, very hard for migrants and displaced to access gender-based services, as police personnel consistently abused them due to lack of proper documentation. This quote from a provider in the US kind of sums up the challenges in the US, where fear is intentionally used to bar people from accessing essential health. They have to cross through checkpoints like ICE checkpoints, and people are not going to do that. So just some broad failures of governance and implementation that we can spot based on our rapid assessment. National governments were woefully underprepared to address the gender-based violence crisis during the pandemic, and particularly for people on the move. The pandemic put tremendous stress on already weak gender-based prevention and response system, particularly weak for migrants. There was huge confusion regarding which services were open and available, changing regulations, poor communication, and particularly poor communication to migrants. In many places, gender-based violence services were not deemed essential at the start of the pandemic. I forgot to tell you to move the slides, so let's move through them. Sorry, I got all excited about the rapid assessment. Okay, right, that's great. So even when services were available, restrictive policies and related factors meant that migrants were kind of at the bottom of the list. We've mapped where GBV services were deemed essential and inessential, and it's a complete and total mess. So this, next slide, please, is a justice issue. Of course, migrants were among those impacted first and hardest by the pandemic and have the largest challenges. I also like to say it's a science issue because until we all deal with the pandemic, nobody's dealing with the pandemic. Governments have seized the opportunity of the pandemic to push anti-immigration and anti-reproductive health policies. In the US, obviously, it was used as a pretext for blocking asylum seekers. Numerous restrictive policies were put in place to stop essential and reproductive health services. Only 12 states included abortion as an essential service here. There was tons of litigation around that. So lots and lots of issues. Looking ahead, we know that COVAX has promised 5% of the total vaccine pool be kept aside for acute outbreaks and humanitarian organizations. That's a ridiculously low number. As countries consider closing their borders to people who are unvaccinated and migrants are left out, all of these issues that I've described will increase. I don't know if I'm out of time. I'm good?
Yeah, I think maybe just 1 minute, if you could.
Okay. So just the vaccination picture, and I know our colleagues will talk about it more. Just to say, in my lawyer capacity, there's no transparency about all the deals that richer countries are making with pharmaceuticals. There's no transparency about what vaccinations actually cost. There is a lack of participation and side deals in COVAX. Of course, there's tremendously good things going on as well, but I am the justice human rights person, so I'm going to talk about the problems. So I think we have to really pay close attention to equitable vaccine rollout with migrants being at the head of the list. So I'll stop there.
Thank you, Terry. There were so many things within that talk, and I would ask anyone listening, if you have questions, please put them in the Q&A function and we'll come back to them. But can I ask one question? Because there have been pandemic preparedness plans across the world within sort of CDC and our own equivalents. But what factors do you think led to this unpreparedness of governments to look at gender-based violence and the crisis, and particularly amongst migrant populations? Why are we in this situation?
So we see really across the board a failure to integrate migrants in national health and social protection systems, and kind of a reliance on parallel humanitarian systems, which tend to be dependent on staffing from outside the community or subject to other UN security restrictions on mobility. So it's kind of a setup for disaster. We see across the board a lack of clarity around what are essential services, both in law and policy, and certainly what that means for people on the move. We see lots of poor coordination. There was a lot we learned from Ebola around gender-based violence. Not in very few places did we see what we learned implemented. And when we did see it in our rapid assessment, it was in response to community-based organizations making some kind of trouble.
Thank you. And I'm sure we'll come back to these issues in the other talks as well as the questions afterwards. Thank you very much, Terry. Move on to our second speaker, Dr. Ligia Kiss. Ligia is a colleague of mine in the Institute for Global Health in UCL. She's an associate professor of social epidemiology and also holds an honorary post at the London School of Hygiene and Tropical Medicine. For more than 20 years, she's researched on violence, human trafficking, and health. She's got methodological expertise in research designs, evaluations, particularly of complex interventions. She's interested in the use of system science, realist evaluation, and computational social sciences to advance research, intervention, development, and evaluation. Thank you, and over to you, Ligia.
Sorry, just sharing my screen with you. Sorry, can everyone see the slides?
Yes.
Thank you. So first, I would like to thank you very much, Dylan and Lucy, for organizing this timely and so important event. And I would also like to thank Sofia Labanov-Rodzvinsky, who did her master's with me and kindly agreed to share her findings in this presentation. You can see a picture of Sofia in the left corner of this slide, and she'll be available to answer questions on her research after this talk. I'm going to talk about the impact of COVID among vulnerable female migrants. So those migrants that are more likely to experience violence, abuse, and exploitation in their migration. Evidence is still very scarce on the impact of COVID, but data is emerging on the effects of this pandemic at each stage of the migration cycle. At origin, Terry mentioned some of the restrictions that the governments have been imposing. Those were not those who try to escape this violence many times enter irregular channels of migration, facing unsafe routes, travel restrictions that make them more likely to fall prey to smugglers and traffickers. In addition to that, mechanisms for identification and rescue of migrant survivors are working much less effectively when they are at place still during this pandemic. At destination, we're seeing that lockdown measures have increased exposures of migrants to GBV and has reduced opportunities to access prevention and response services. Today, I'm going to focus a bit on the transit and destination phases, and I'll bring three vignettes, one on transit, on to a destination, that will serve as examples of how COVID is and might be affecting the life of some of the most vulnerable migrants in the world. I describe the methods we use and give you the publication sources if you want to check this in more details, but I won't go through that now. The organizers are going to make these slides available later, and you can read that if you're interested at a later stage. So the first vignette on gender-based violence risks during transits focus on Nigerian female adolescents migrating to Europe. These adolescents usually travel by land. Our research indicates that something as 96% of them go by land through Niger and then reach Libya. They travel the scorching heat of the desert, facing kidnap and extortion by militias that operate in the border with Libya. They face abuse by smugglers in Libya, as well as during their transit to Libya and in the crossing of the Mediterranean. The interviews that we conducted have showed that they face all kinds of abuse, including forced labor, sexual violence, physical violence, emotional violence, restrictions on the freedom of movement. With the COVID-19 restrictions, We had in May, Libya's announcing that their air and land borders were closed, leaving migrants stranded in Libya. So their only choice to get out of Libya is now crossing the Mediterranean, where in March, IOM has announced that search and rescue operations were suspended in the Mediterranean. So a journey that was already incredibly dangerous is now unimaginably difficult. The second vignette is on risks at destination for workers, female migrant workers. And I brought the example of living female domestic workers in the Gulf countries. We conduct research pre-COVID with Nepalese and Bangladeshi migrants, and the levels of violence that these women experience are unimaginable. For example, in Nepal, we interviewed 500 refugee migrants, and 90% of them responded to our questions of abuse, exploitation, and violence in a way that they could be classified as having experienced forced labor according to the definition by the International Labour Organization. The perpetrators of this violence are usually employers, their family members and acquaintances, but often police and local officials turn a blind eye to it. The lockdown restrictions have made their exposure worse, have increased their exposure to these perpetrators and family members because they are spending more time at home. Therefore, these women have been seeing increased levels of abuse and violence and have to face increased load of work that is not compensated for. And finally, I would like to touch on the responses for migrant survivors, and this is based on the research by Sophia. The population that we'll cover is displaced Yazidi women and girls in northern Iraq. They are a Kurdish group that have been persistently persecuted because of their minority status. More recently, they suffer attacks by Islamic states, resulting, for example, in the displacement of 400,000 people, Yazidi people across northern Iraq. Women and girls as young as 8 were subjected to sexual slavery. And they have really high rates of PTSD, between 70 to 90%. Restrictions associated with the COVID-19 pandemic has meant that access of workers to the sites where they live, communicating with them via online systems, have meant the interruption in service provision, or in the cases where service is still being delivered, the availability and quality has decreased. With funding priorities redefined, this population is also being further marginalized. This is the results from Sophia's research, and she identified 7 mechanisms that psychosocial interventions depend on for their effectiveness. And in each of these mechanisms, the providers that Sophia interviewed identified negative impacts from the COVID-19 pandemic. Again, Sophia is in the panel to answer more specific questions about her research, but I wanted to bring an overview of her research to you. So finally, the conclusion from this presentation is that risks of violence, exploitation, and abuse, which were already incredibly high for these marginalized and often invisible populations, apparently have become even higher. In addition to that, we have the pandemic contributing to invisibility of their situation because of funding being redirected from essential resources that were previously available to them. And research efforts that document their situation are also hindered by the pandemic. finally, I brought all the references and some of the collated evidence for you if you would like to learn more about it when the slides are made available to you. Thank you very much for this opportunity to share these findings with you.
Thank you, Ligia. And related to the last points about, can I ask you, and maybe Sophia as well, I mean, what do you see as the key research gaps in gender-based violence, migration, and COVID in this intersection?
Well, I have to say, in terms of GBV, one of the worries that one of my concerns currently is that we've been treating violence, gender-based violence, as violence against women. And after researching sexual violence against men in conflict settings and the lack of access to services, this is one of my concerns, that the services that were already scarce and almost inexistent for this population who also experience gender-based violence in very severe forms can be further jeopardized. And also, obviously, I think also of the LGBTI plus population who might have increased difficulty in accessing the services. And I think a final point is related to the vaccination. If this population who are engaging in regular migration from dangerous route, facing all kinds of risks, they will have very little access to vaccination in states that don't even recognize or are aware of their presence there. So yeah, I think those would be two of my concerns related to GBV. Sophia, would you like to add anything to that?
I think just to reiterate what you said, I'm working for a charity at the moment who support migrants gaining access to vaccinations and testing due to COVID. And I think there are a lot of issues with the fact that migrants are undocumented and don't have access to GPs, and that's their main route to getting a vaccination, which obviously is an individual health issue as well as a public health issue. There's also a lot of hostility towards migrants when they do turn up to their testing centres. So on the NHS website, it asks for you to bring some form of identification, and a lot of migrants are very terrified of being called up by the Home Office and deported back to these situations where they are in a lot of danger. So yeah, I completely agree with what Ligia just said.
Thank you. Thank you. I'm sure we'll come back to some of these issues later on as well. If we could move on now to the third speaker, I think, Ligia, you may have to stop sharing.
Sorry.
So
Technology.
now to Dr. Ines Kenyard, who's an assistant professor in sexual reproductive health in the Department of Public Health and Primary Care at Ghent University. She's also the team leader of the Gender and Violence team, coordinating research on violence prevention and response, sexual and reproductive health rights violations, and on gender and sexual health promotion in hard-to-reach, vulnerable and minority groups. In addition, she's a founding member of the Centre for Social Studies on Migration and Refugees, member of the Commission on Sexual Violence, as well as a member of the Commission on Human Rights of Ghent University. Ines is involved in numerous studies, international studies, looking at the holistic care of victims of violence, sexual and gender-based violence prevention and response, on migrant health and acceptability of care in vulnerable populations. She's developed guidelines on violence prevention tools, training programs for many different settings, and regularly provides consultancies for UN organizations and several governments. Some examples of these are the European Study on Inclusive Care for Refugee Victims of Sexual Violence, the first gender and age-sensitive sexual violence prevention study in Belgium, the Relationships, Stress and Aggression in Times of COVID-19 study, and she's developed and piloted and evaluated the first 3 Belgian sexual assault care centres. Thank you very much, Ines. Over to you.
Thank you, Vignette. Many thanks to UCL and Lancet for inviting me. I think this is a very interesting seminar, and I hope that I'll be able to share my screen now. I suddenly have 3 versions. Could somebody tell what you see and how many slides you see?
It's not on presenter mode, but I can see the PowerPoint. Yep, that's it.
That's it? Okay, many thanks. So I think one of the main issues, if we look at sexual and gender-based violence and the policies and the political perspectives, we first have to look at definitions. What's in the word, what is in the policies, and what is in the law? As such, it takes three parties to commit sexual and gender-based violence. First, you have the victims who are exposed to several violent acts. And if we look at their perspective, there could be a factual perspective of what happened to them. On the other hand, you also have assailants who are committing sexual and gender-based violence. And often if we define, if we have definitions, then we look at the motive or the relationship between the assailant and the victim. But of course, you also need a society who is interpreting those acts, facts, and motive and decides on the reaction to give and decides whether it's a crime or not. And if we look at current policies and on current definitions that are used in policies and laws, it often does not cover the full spectrum of SGBV, and it's often not evidence-based in the sense that it's not sufficiently updated, and laws often come too late. If you look on definitions on sexual violence, for example, in 2003, WHO had in the official definition of sexual violence, the notion of consent as something that's very crucial, and that there was no consent, and also coercion. That got reflected also in the Istanbul Convention in Article 36, where it said that all countries and countries that ratify and governments that ratify the Istanbul Convention, that within their laws, they should have this consent as a core concept of sexual violence. Now, in 2015, WHO changed its definition, something that we really support, to dropping the element of that notion of consent and coercion as being central, but it's about sexual acts that are committed against somebody against one's will. So that's much broader. Now, also in the scope of sexual violence, often it's only limited to physical contact and to sexual violence with penetration. Well, there are a lot of forms of sexual violence that are hands-off. So forms of sexual harassment that can be either offline or online, and it also includes sexual neglect and disrespect of sexual intimacy. But also being forced to commit sexual violence is a form of sexual victimization and is often not seen or translated within the laws, and especially in the context of sexual exploitation and sexual violence as a weapon of war. This is rarely integrated. Now, SGBV policies also reflect some rape myth acceptance. And if we look at ideal victim theory, that already dates back to 1986, Christie has said that an ideal victim responds to 6 criteria. Per definition, the victim is female and weak, because she's a woman. She's conducting a respectful activity at the moment that she's being sexually victimized. She's at a place where it's okay to be as a woman. She's assaulted by a big, bad and male assailant who is unknown to the victim. And if you do not fall in that category, then you cannot be a victim of sexual violence as such. So this makes that everybody who supports this theory, and it's been introduced in a lot of laws and policies, that women are per definition the victims and men the assailants. So this ignores male victimization, which impacts their health-seeking behavior, which impacts subsequently their health outcomes, and might even lead to perpetration at a longer run. Migrants in transit, applicants of international protection, and undocumented migrants are not ideal victims according to this theory, because migration is not a respectful activity, but it's a high-risk activity, and male migrants, if I abbreviate to MAR, are often perceived as sexual predators and cannot be victims, and MAR women are per definition also oppressed, while in reality we see that this is of course not the case. Now, if we look at legal and policy frameworks around SGBV in MAR, we really suffer from some othering practices. As such, already sexual health is very much linked in those policies to reproductive health, and then it's a bit seen as a public health threat regarding STIs and HIV. It's also more an outsider problem because the types of sexual victimization that are included are mostly sexual violence as a weapon of war. It's about trafficking and it's about FGM. And it's all about violence against women. So even in the Convention of Istanbul, It's really in the title, it's on violence against women. So again, we ignore male victimizations, and a lot of vulnerable groups as sexual minorities, as sex workers, as undocumented migrants are not sufficiently addressed in those policies and policy frameworks. And also the country of origin information that is taken into consideration when people want to apply for international protection is often unreliable. There are also lack of national and subnational prevention and response policies and tools, and even if they are out there, they're rarely implemented. From my own research, I had 3 key findings. That there's a very high prevalence of sexual victimization in all genders, not only in women, and is often combined with other types of violence. There's much more gang and multiple rape, which is often committed as bail for passage compared to regular citizens. Professionals and people in authority are often a substantive part of the assailants. But this is perceived as collateral damage of migration and is often not addressed in those migration policies, except for those cultural lens forms. And in COVID-19's MAR are out of the picture. They are often locked up in centers and camps where there is a high stress. And we know that high stress, as several researches that we've done now in COVID, increases also the risk of victimization. We know that sexual and gender-based violence might induce a very broad range of adversity, that psychological, physical, sexual, and reproductive level, also socioeconomic. And if they're not treated well and supported well, then there's a risk or high risk of re-victimization and even of perpetration. And there are also intergenerational consequences. So here are some quotes of refugees that I interviewed, showing, for example, this quote of Olga, who said, "I tried to abort a child when she became pregnant after being victimized by several men, but nothing worked. So I asked a friend to penetrate my uterus. Within all, I lost a lot of blood and was transferred to hospital. The doctor told me, after this torture, you cannot get children anymore. That's the worst thing that could happen to me." Parvana said, "Fear nightmares, we all know it. My children can't bear loud voices or noise. They have forgotten the meaning of the word joy." So she puts in her own words that her children suffer from PTSD. And then Ilikia also said, "The day after the 2 women were raped, our men transported them, but the women could not talk. And so they were completely in shock. Then we had to leave them behind because the men could not carry them anymore. Given where they were, so in the desert, they certainly died. This hurts because we walked together." And this collective trauma is often something that is forgotten as well. We ask about they have experienced something, but not especially if also they were aware or if they were exposed to victimization. Another problem in the policies that they are often emphasizing detection. Migrants often see the victimization as some rite de passage, as a rite that is linked to migration. You have to endure this to become a real migrant, or they park their suffering until they are arrived in destination country and their primary needs are fulfilled. But many suffer also from those incorporating othering. They think they do not deserve to ask for good protection and care. So those SGBV policies in transit countries are focusing on detecting victims, on protecting and sheltering them, hospitalizing them if necessary. But a lot of migrants, when they're in transit, they prefer that group protection. So if you take them out of the group, then they will escape. That's what we saw in Europe, for example, with many unaccompanied children. They were taken out of their group, but they ran away, and then they were at even higher risk of SGBV. It's also advised again to question about sexual victimization if you cannot provide adequate care. So it's better not to question that too much than not much in depth. Migrant professionals are rarely skilled to discuss SGBV, to refer and to care well. There are quite some guidelines and tools out, but they are often not known or not implemented. And people in authority were often their assailants in the past. So why should they trust the new ones who are asking questions about sexual and gender-based violence at this point? We know that SGBV can have long-lasting ill health consequences and that there's a
1 minute, please, Ines.
trauma. But in the accommodation facilities, they rarely implement those guidelines. The access to services and justice is very limited, and the entitlements are often linked to their legal status. For example, in Belgium, there is no safe reporting ensured. So even if undocumented migrants come forward, they can get the care in the sexual assault care centers, but we cannot guarantee the safe reporting procedures. Those healthcare providers are rarely well trained in holistic care, not about MAR victims either, and they're sometimes in some countries obliged to report to the police. In COVID-19, we saw that public health owned citizens first approach. So borders were closed. There's no possibility to apply for international protection. Lockdown and movement restrictions sucks. If they were open, they were difficult to reach. So there was no care, no control, no protection, or there is still. So there's still a higher risk and a higher impact of health. So to conclude, there's double interaction between sexual victimization and legal status. The policies often ignore victimizations of migrants of all gender and sexual orientation, which hampers effective intervention and effective policies, which leads to a high burden, re-victimization and perpetration. They also suffer from othering and bordering practices, ignoring sexual victimization in their own societies and structures, and the emphasis on victims who need to speak up to get assistance and care is victim blaming as such, and is also epistemic injustice. So in COVID-19, citizens were put first, and MARS was more seen as a public health threat, so they were also out of the question, of the picture. So to end with a quote from an Afghan refugee in one of my studies, he said, "You need healthy people to build a healthy society." So I wish you all an excellent health. Thank you.
Thank you very much, Inez. Just one question briefly on this idea of systemic injustice, and how has that played into the multiple jeopardy of COVID-GBV migration? And are there any key strategies that may help to overcome this and improve health?
Yeah, well, systemic injustice is a bit linked to what we call hermeneutical injustice and testimonial injustice. And hermeneutical injustice occurs when people are wronged in their capacity to make sense of what is happening, of their social experiences. And it's often linked to their marginalization as a social group. So it's difficult to understand and put words to what is happening or what they experience because there's no collective understanding that this could happen to them. And this is caused by structural prejudice that is linked to their social identity of migrant. And the testimonial injustice occurs when somebody is wronged in their capacity of giving knowledge, of telling what is happening. And that's also linked to that prejudice of their social identity as a migrant. They cannot be believed to have experienced, for example, SGBV. And it becomes systematic when those prejudices, people are not given credibility. They do not know how to put words to what they have happened, to what have happened, because they don't think it can apply to them. And we don't believe them if they try to tell it. And it becomes so the systematic when those prejudices track through different dimensions of social activity. For example, at the economic level, at the educational level, professional level, legal level. So this injustice is done to migrants in general. I think they are not perceived as a trustworthy source of information because it's often thought like they probably make up a story to benefit from our services here. And in the case of SGBV, even more, because the collective understanding is such that SGBV, they suffer, is linked to their own culture, to war, to everything related to their identity as a foreigner, and not to SGBV as such that they might have been exposed to in the receiving country. And even if they come across as rather convincing in their story, then it's often victim blaming in the sense that we see it's their own fault because they should not have taken those risks. And for male victims, it's even worse. They are not considered to even be victims. So in the COVID-19 times, they do not even have the possibility to come forward to disclose what happened to the SGBV that they suffered. So they don't even have the chance to be not believed. They are structurally silenced.
Thank you. And Terry, we may come back to that from your perspective afterwards as well. I guess is particularly an issue at this moment. But given the time, I think it'd be better to move on to Joseph first for his presentation. So Joseph Bartovich is a technical officer in the Migration and Health Program at the WHO Regional Office for Europe. Joseph worked for the Regional Commission for Western Asia of the UN Secretariat in Beirut, where he covered migration in the Arab region. And then after completing studies in politics, worked for the Ministry of Health, Public Health England, and the National Health Service in the UK. Now at the World Health Organization, he works primarily on evidence generation and dissemination, including the Knowledge Hub on Health and Migration. Thank you, Joseph.
Thanks, Dylan, for the introduction. Very good afternoon, everybody. It is a great pleasure to be part of this important webinar dealing with an important topic, a complex topic as well. And it brings in many layers and many sort of complexities and factors from migration to the pandemic, violence against women, inequalities, gender inequalities, and some of these factors are reinforcing and sometimes might be also quite difficult to talk about it all together. So I'm actually going to try and disentangle some of this, and in my presentation address some of the issues on their own, and then slowly bring it all together towards the end. But first, I would like to talk about violence and in general, and then specifically looking at gender-based violence, and then sort of bringing a bit of COVID as well. Most of this will be also looking at some of the tools that we offer at WHO. We are working a lot with policymakers, and I think it's been very interesting to hear about the research, hear about what's going on the ground in terms of some of the projects, and also in terms of the latest research and evidence that our colleagues here are bringing to the foreground. But we are also very interested in this, and also in terms of the sort of practical steps and work advising governments on how to deal with these issues going forward. And one example of this work, not specifically looking at gender-based violence, but looking at violence, is the work on the technical guidance on, my screen has frozen. Are you able to see my slides? I'm not able to move. Oh yes, now it's going.
Yeah, it's
so
working now.
It's work on our technical guidance on preventing and responding of violence and injuries in refugees and migrants. And this is a technical guidance really trying to develop interventions to prevent and effectively deal with violence in refugees and migrants in general. It has sort of two main areas. Firstly, sort of bringing together the available evidence, and then making policy recommendations that our governments could be taking forward in terms of addressing these issues. Just quickly, some highlights of the evidence. So we know that the incidence of harm is, in terms of refugees and migrants, is very high at all stages of the migratory process. I think we've heard it also from the other presentations. We have three main migratory routes into our region, and the central Mediterranean route, so the one going from sub-Saharan Africa through Libya to Italy, seems to be the one which is consistent with most death and most incidents of violence. And we were also looking at some studies, and one which was particularly interesting was a study from 2014, where MSF have looked at a group of almost 2,000 patients. And they were interviewed about their experience of violence, and 85% had experienced one or more episodes of violence. Nearly 10% had experienced violence after arrival to Europe. So this is also very interesting from the policy perspective, in terms of not just looking at the migration trajectory and the border crossings, but also actually having programs in place for migrants after they arrive in countries. Now, Ines has already sort of disputed the ideal victim theory, but we also see from the research that there are some particular groups which are more vulnerable. Being irregular migrant, being asylum seeker, refugee appears to make a difference and make an individual more vulnerable to sexual gender-based violence. Children and youth are particularly vulnerable subgroup, and we have almost 1/3 of all detected trafficked victims globally being children and migrant children in Europe are at greater risk of exploitation, especially those unaccompanied. We have also reported high burden of violence faced by migrant sex workers. 65% of sex worker population in Western Europe, and 16% in Central Europe migrant sex workers. And also a big issue is hate crimes. We have public discourse and also political discourse, which is often quite it can incite hate crimes and can also contribute to exacerbating these problems. So I think this is also an issue that we were looking at in this guidance. And then there are some policy areas, 5 in total, based all on sort of human rights and law enforcement and migration, human rights above, putting human rights of refugees and migrants above law enforcement and migration management objectives, making sure that member states are protected to promote and protect rights of all people in their jurisdiction without discrimination, without migratory status, and also based on the principle of obligation to place the needs of victims at the center of efforts to combat violence. And so the areas that we are focusing on are ensuring safe passage, addressing the causes of violence, identifying victims and providing care, but also investigating and prosecuting the perpetrators and strengthening the knowledge base. And these go quite into detail in this piece of work. For example, the one on identifying victims and providing care and protection, with making some concrete recommendations in terms of strengthening the mechanisms for identification and referral at borders to ensure children, in particular irregular migrants, unaccompanied children, victims of trafficking and groups vulnerable, other vulnerable groups have access to psychosocial support, legal services, accommodation, and so on. Conducting mental health assessments and making sure that these have specific evaluation in regards to the experiences with violence, and also preventing mechanisms for some of these groups. And also, for example, strengthening policies to ensure victims of sexual, gender-based violence and domestic violence are provided with support and enabled to leave abusive relationships and without any consequences, also to their migratory status, residence status, and so on. So this is a resource that is being drawn on by our member states and by our governments. And it deals, as I said, with the issue of violence in general, but it does have relevant recommendations and considerations for sexual, gender-based violence as well, and also in the times of COVID. Now, in terms of violence against women and children, this is also another area of concern. And on the actually 12th of April, so fairly in the early days of the pandemic, our regional director has made this sort of a center point of his press conference, the COVID press briefing, and was focusing on violence against women and children in emergencies and during this pandemic. And I mean, there are many different pathways and sort of factors which are impacting violence against women. We have seen all and we have actually even mentioned already today, the decrease in services in terms of access, but also in terms of the service availability, social, but also statutory services. Then this leads, of course, to disruption of social and protective networks, stress factors, and so on. We have been trying to raise awareness of these issues, both in terms of governments and also in terms of health systems. And I provide some of the material that we have been sharing there as well. In terms of the data and evidence, we have heard again a lot of statistics, but the number that I always take away from, and this slide is actually from our colleagues working on gender, and I have borrowed it, is the 1 in 3, right? 1 in 3 women worldwide have experienced physical or sexual violence. In the WHO European region, it's slightly different. It's 1 in 4, but still staggering numbers. And of course, violence against women has many forms, from sexual violence, femicide, human trafficking, to the most spread form, which is intimate partner violence, which could be physical, psychological, or sexual. So this is one layer of the complexity. Then when you sort of overlay it with the migration issues as well, there you have another set of burning issues and staggering or sort of shocking numbers in terms of, for example, the studies that we've been using for the technical guidance, suggesting that 69% of migrant and refugee women have been exposed to sexual violence. 1 in 3 women raped by a stranger or non-partner in conflict areas. 71% of victims of trafficking being women, and of those 83% being trafficked for sexual exploitation. So this all has consequences. It has now, of course, been exacerbated in times of COVID by border closures and restrictions. And this has then further impact on, puts pressure on female refugees in risk of sexual violence. Humanitarian corridors have also been restricted. And a lot of female refugees have been denied protection against sexual violence, which is a human right violation. This has, of course, health implications, and we know again a lot of these statistics, but it has impact. Women who are facing violence, we know that are exposed to twice likely to experience depression. They're almost twice as likely to have alcohol use disorders. We know that 16% are more likely to have low birth weight baby. They're at higher risk of acquiring HIV, the higher risk of death, injury. And we know that 38% of murders committed by intimate, of women are committed by intimate partners. So this is why we are, again, very concerned about this situation. And we have put together a number of resources for policymakers to address the situation. So that the ground is really set by the resolution from our regional committee, and then we have the strategy on women's health and well-being. We have the action plan, global action plan, European action plan, and also the strategy and action plan for refugee and migrant health, which in different instances and different ways are trying to address the situation and support governments in getting this right. Now there is also
1 minute, please.
Yeah, thank you. Beyond that sort of political level, there is also there are some practical WHO tools which we're trying to put out there to support countries to address violence against women in our region, European region. And this is both in terms of the evidence and we provide prevalence estimates and health effects and so on, but also then have some tools both at medical legal levels, but also clinical. And then also we have a handbook for health managers and so on. So this is where I would like to leave it, and perhaps I'm happy to also continue as you wish, or take some questions.
Can I ask you, thank you, Joseph. Can I ask you just a little bit about some of the challenges you faced, or the WHO faced in the rollout of this technical guidance, and were there any barriers, and how did you overcome those barriers in getting partners to use it?
Well, in terms of challenges, I think firstly, lack of awareness of the legislative frameworks, the legislative mechanisms, the different policies and sort of toolkits that we have in place, but also the failure to enforce them, right? So that's, I think, first issue, and constantly we have to work to promote the take-up and dissemination of these policies that we try to promote. Another problem, I think, is violence and punitive approaches for refugees and migrants are often bolstered by, and I've already mentioned this in my presentation, by the current discourse, by the rhetoric, political but also public, And such sort of discourse and rhetoric often contributes as a risk factor, I think, to violence against refugees, violence against women. And this is also particularly so in countries which are perhaps less used to receiving migrants who are trying to immigrate and settle in those countries. So that can be sort of exacerbating violence in general. And I think then also the other thing is the issues around political leadership and commitment. Again, we have, as you can see, the research, we have presentations today, we know a lot about these issues. We have some tools, we have toolkits, we have good practices, we have policies, but really I think we all need to work towards making sure that we raise awareness, lobby, promote, and get to a point where political commitment is very solid on these issues.
Thank you very much, and thank you to all the speakers. We have about half an hour left, and we'll kind of open this up as a panel. So I'll ask some questions, and then if any of you can contribute. So the first question I thought was picking up on one of your points, Inez, about this idea of systemic injustice, and also the idea of othering. So migrants are often othered anyway. Certain migrants othered more than other migrants, if that makes sense. And in issues of gender-based violence and circumstances of gender-based violence, there's a lot of stigma attached to this as well. And I guess both Ligia and Inez talked about groups, men, LGBTI groups as well. And I wonder if you could speak on this idea of othering and what steps we might take to address this. And Terry, specifically to you, this idea of testimonial injustice and how this affects what you do from a legal perspective, particularly in a time of COVID. So if any of you would like to pick that up.
Nez, I can answer.
Please.
There's a couple of things I just wanted to say. I think, and then I'll answer specifically. We have been really doing a lot of work trying to sort out what is being funded in gender-based violence, like interventions that are most funded. And what you see is really a total lack of attention to the structural factors, a total lack of attention to these kind of legal systemic injustices. In some places you see only sexual violence actually having any access to any legal remedy. But you see a lot of funding to kind of interventions that focus on self-esteem or economic improvement, and they ignore, shockingly to me, the fact that in many instances the women and girls don't actually have the ability to enter contracts or access legal, or in the case of LGBTQI people, they're illegal. There's a lot of interventions around reducing child marriage, which involve things like drawing pictures, right? I think we need to get way more serious about the systemic injustice, the laws that are being applied, what is being funded, because, big initiatives, not to call out any of them, often the money for the humanitarian interventions is going to governments or it's going to large INGOs, which may not be listening to people on the ground at all and may not even know about these legal kind of complexities. So I think we have to go get much deeper into kind of what's going on in all of this, including what are we calling interventions around access to justice? Because when you really look closely, there's a lot that needs to be sorted out.
Thank you. Inez?
Yeah, thank you, Dan. I fully support what Terry is saying. And I think also not only at the justice part, but also at the care part. I think we are still othering a lot of migrants, and then especially also if they are a victim of sexual violence, and if they are then on top of that part of a sexual minority, or for example, a sex worker, and if they have multiple minorities, then you get this intersection of othering, which also makes those othering-based stress that they have, make it bigger. And so even the trauma that they may accumulate become bigger, and it becomes also more difficult to address. But for example, if a male victim now goes forward, and if there is a sexual assault care center or sexual assault referral center, if there is one in a country already, the chances are quite high that he will not even be able to enter, not as a migrant, but then also because he's a man. So that ideal victim theory also goes there, and care workers, that they don't see that male victims can be a victim. And then often those care centers are often based within the mother and child wards or in gynecology wards. So it's already not an environment where a man wants to come forward and speak out, and then he will often not be believed what has happened, but also for several migrants, depending from their country or origin or their specific culture. For example, if they have been penetrated, they might assume that they have become homosexual while they're not. So they already have a problem of understanding themselves, what happened and what that means. And if then, for example, you have a care worker that has, or an interpreter that needs to translate and interpret the conversation with the healthcare worker who has the same origin, he's not going to say that he's been anally penetrated, because that could cause harm to his society, to his culture, to his community, and that might come to unrelated violence, for example. So he's not going to tell that. So there's that othering has an effect on multiple levels, I think, also at the care part.
Can I just add to that briefly, just to echo what Terry raised in terms of neglect of the structural factors and lack of contact of the big NGOs or governments with the reality on the ground. We just, in 2018, we finished a large 5 years evaluation of the Working Freedom Program, which was an intervention by the International Labour Organization to prevent human trafficking. And they relied on a strategy of empowering migrants to promote safe migration. To cut short, the evaluation findings were more complex, which were more complex than what I'm going to say. Basically, the idea that women would migrate from rural regions in Nepal and feel empowered to negotiate in a foreign language with recruiters in a complex chain of recruitment and get to Lebanon, Saudi Arabia, and face their employers with that complete barrier of otherness, and stand to them and say, I know my rights, you cannot abuse me or exploit me. It's so unrealistic. It's just, it sounds like a joke. So I just wanted to bring that example. So to echo Terry's word that we need to take this more seriously.
Joseph, do you have anything to add?
No, Dylan, I think that's been covered. Thank you.
I wonder, Sophia, actually, in some of your experiences at a maybe a clinical level that you described, has these issues come up?
I'm not a clinician actually, but through my research on the Kurdistan region of Iraq, I think we had very similar issues which were told to me during my interviews. So the narrative about empowering women and that's going to solve all the issues, it's been around for centuries that women are discriminated against, whether this is within the local economy or within the law. So for example, any child who's born to an Iraqi woman is always takes the religion of the father rather than the mother. So there are always a lot of issues, and particularly with Yazidi women who have given birth to ISIS fathered children, they will always be a Muslim, and that causes a lot of issues with social rejection of these women within their communities. So I think that's a really important issue, and even more structural things about poor internet connections. So a lot of people can't access online therapies even though they wanted to, or the education system. There aren't any Yazidi schools to learn about their religion and within Kurdish, speaking Kurdish. So I think you are, again, sort of trying to squeeze out something which it won't fundamentally work unless you change all these structures and look at them within their whole socio-ecological model of their existence, within which their health is situated. So yeah, I would completely agree.
Great, thank you. So what do we do about this? How do we address, mitigate some of these risks? What are the key policy changes you'd like to see in light of this combination of migration, sexual gender-based violence, and now COVID-19 on top of that? What should we do? An easy question for all of you.
I do think accountability, like all of the kind of recommendations and existing policy documents. Again, our research showed that they were routinely ignored. So there's that. WHO has put out amazing materials, right? And we kind of did our questionnaires based on what was recommended and routinely saw it ignored. Accountability, I think actually starting to push on in the places we're using RCTs to establish that women are more empowered when they take these 6 classes. I think we need to question evidence. Is this the appropriate way to measure what works in this context? How do we get at structural factors? How do we actually disentangle and look and make the INGOs understand what actually the international law is? So I think it's about going much deeper and being more strategic and helping local folks infiltrate some of the leadership opportunities that exist around kind of what's going on. That's not, people think leadership and they think of this vague kind of public speaking, but leadership in terms of strategic infiltration of kind of folks who are making decisions around humanitarian aid, et cetera. There's very little local participation. There's very little women participation. So I think we have to get at all of that and the specifics of it and start to question some of how the funding is being done, et cetera.
Do you think in COVID this is going to be easier or more difficult? And I can see it going different ways. Health and health issues are now at the forefront of everyone's thoughts. People know what public health is. On the other side, huge economic downturns probably in the future, massive, but potentially policy changes, recessions. I mean, do you think this idea of accountability and pushing a health agenda, will COVID facilitate or restrict it?
Interested in what others think. I mean, I've just been very involved. Sadly, it's very reminiscent to the work in HIV that I did around kind of equitable rollout of treatment and vaccine. So there's so many issues with COVID around kind of access to vaccination. I think, what we're seeing around the world in terms of incarcerated populations, migrant populations, it's a kind of catch-22 because nobody's going to be out of this pandemic until everybody's out of it. So I don't know how it's going to go.
Joseph, would you like to come in and possibly on the accountability point that Terry raised specifically as well?
Yes, I like the accountability. I like the sort of the idea about infiltration and also about participation of those who are concerned in the decision making. From WHO perspective, I really think we need to continue to generate the high level commitment, despite the fact that there are some frameworks and some policies already. We need to sort of keep bringing this constantly on the agenda of ministers of health, be through the World Health Assembly, our regional committee, and also bilaterally. This has to be an important component of sort of meetings that we have with ministries of health. I think in terms of migration, we have the strategy and action plan. This is coming to an end. It was actually one of the sort of commitments of member states which had an accountability framework, monitoring every 2 years how member states in the 53 member states of the Regional Office for Europe are doing on implementing some of the strategic areas, not all. We only have 4 indicators, and it has been very helpful to have it and to see the progress. But also we survey member states, so we see what they're interested in working on. We see that they're interested in data and monitoring. So we have now put that topic on the agenda and trying to help them with data and disaggregation of data by migration status, which consequently will hopefully also be able to tell us more about gender-based violence among refugees and migrants. But so I think, yeah, accountability is important. So bringing it to the attention of decision makers and high-level people in governments. And then, yes, of course, having accountability frameworks. We're thinking of having a high-level meeting at the end of this year on migration, and making it part of that agenda would be important. And then if we do have a new strategy or framework or roadmap again for another 6 years of migration health in Europe, of course, we need to have some way of making member states accountable for this. You do hear a lot that we have all these frameworks, not just on migrant health, but climate change, and you name it. And then actually by member states, by signing up for that, they actually de-responsibilize themselves because they say, we're part of this, we support this. But actually, when you look at the work, that's not always following through the commitments. So we really need to make sure that commitments are followed through, and that we are able to see the progress, and also that we have the data. I think data is important as well in this. I think that's it from me for now.
Thank you.
Space for someone else.
Thank you. Can I go to you, Ligia? And Terry raised the point of evidence, and is it the right evidence? And we have a question from our audience to say more about questioning the RCT design in the process of producing evidence. I wonder if I can put that to you, actually, Ligia, rather than to Terry again. If you could talk a little bit more about research and what researchers should do.
Yeah, so I do agree with Terry in terms of the limitations of the RCTs, and especially when the outcomes of these RCTs do not look all the way through the causal links of the intervention. So what I'm trying to say is, if we're trying to prevent human trafficking through empowerment, if our method of choice is an RCT, we should ultimately look whether there was a reduction in human trafficking. If we stop at looking whether women were empowered or not, it doesn't mean much in terms of how effective that intervention was. As I was just given as an example, the Working Freedom Project by the ILO, being empowered didn't mean anything because the accountability mechanisms for perpetrators were not in place. So women who wanted to enforce their rights didn't have the mechanisms to guarantee that this was going to happen. And then to come back to the RCT question, I think RCTs have lots of limitations if used on their own to evaluate complex interventions. I am not against RCTs, and I think they can be used as cluster randomized trials, etc. But one of the things, especially in hard to reach populations, that we need to understand better is the mechanisms through which these interventions work. It's not enough, especially because in my experience, many of these interventions have not benefited from formative research that informs their design. They are based on best guesses, very good intention from people that have not a lot of knowledge about the topic, but they're not based on evidence. In my experience, the majority of them are not. So you're gonna subject to narcity an intervention that's based on best guesses, and you have a high likelihood that what you're going to find is that it wasn't effective, or it was effective for a small group, but you cannot even say that for sure because the sample is so small for that group. An average work, but these populations that are heterogeneous, they are difficult to reach. So you have the problem of representativeness. So I do think that we should not completely give up our cities, but we should explore the use of other methods and approaches that give us a better understanding of how and in which circumstances these interventions work or don't work, and what are the unintended outcomes that they may produce.
Thank you. And I'll come to you, Inez, in a moment. But Terry, would you like to say anything else about that evidence point and the RCTs?
Oh, I agree. I mean, I think if one of the things we're trying to figure out is how much of the really big donors are, how many of them are actually saying, you have to, the evidence standard is RCTs. We're seeing more flexibility, but a kind of, again, a lack of understanding or link to structural factors, or, so I think I think it's going to be a combination of things, but I will say again that I've been fairly shocked at some of the things that have been deemed, evidence of success, because they are not going to change that person's trajectory in any way.
Inez, over to you. So I guess partly back to my original question of what should we do, but also what should we do in a way that doesn't blame victims, that doesn't stigmatize? What do you think are the most important policies going forward?
That's not an easy question. I think we could go on for a few hours on that. About victim blaming, I think one element that we don't have discussed much now is that often before you can get help or aid or assistance or judicial protection or any kind of assistance, you're asked to come forward and to disclose what has happened. But for any victim, this is very difficult. And for migrants, for many, many, many reasons, this might be even more difficult. And I gave one example, just like the man I said in the care, that it could be hampered by a lot of practical things not coming forward. So already as a victim, that's very difficult to do. So for migrants, it's even more difficult. But the fact that we just say that people have to disclose, otherwise they cannot be helped, for me, that's a form of victim blaming, because you put the responsibility of getting help but with the victim. And if they don't say anything, well, then you say, okay, then it's your call, and then you're not going to be helped. And it's the fact that we want to know exactly what happened is often more a problem of the caregivers or the lawyers or the politicians, because they think they need to know everything in detail before they can give assistance. And I don't think that's the case. So that's for the part of victim blaming that we have to take, or to be aware of that in the policies, and then in the implementation of policies and practices, that we try to avoid that victim blaming. I think also what I said at the beginning of my presentation, that it would be good, and for all victims of sexual and gender-based violence, but specifically for migrants, if we broaden that scope of sexual and gender-based violence and have them that it starts from sexual neglect and disrespect of sexual intimacy, and it goes to even being forced to commit sexual violence against somebody else. And so that's that wide range. And also, of course, that evidence that it's not only females who can become a victim of that broad spectrum of sexual victimization. But I think also that in those prevention and response policies, we need to take better those specific vulnerabilities of migrants into account and meet their needs, because it's not the case yet. And I think what Joseph has said as well, and Terry emphasized it, WHO has produced a lot of material, not only WHO, but they have done a lot, and they try to hold policymakers and governments accountable. But what we often see is that even if governments ratify like international directives, or for example, also the Istanbul Convention, that when they have to implement it and they can't, or they can't do it for migrants, for example, the European Directive of Minimum Standards of Reception of Applicants of International Protection. In the case of Belgium, it did not work, and then they say, okay, we'll have a bad report, and yes, okay, the European Commission or WHO will be mad, but so what? And the migrants are not helped. So I think ensuring that even when ratification is done, that that they are held accountable, really held accountable, is something that we still have to strive for. And then I think also in those policies around application of international protection, that what I told about that testimonial injustice, that we need people who are skilled in the virtue of testimonial justice, and that they can hear people well, and that they can listen and understand what is happening and how they should be protected. And this is already the first person you speak to when you apply for international protection, where it can hamper all the rest of the procedure afterwards. So, and then finally, I think we need also better international alignment of policies, because often it's still a regional matter or a national matter, and then even it could be a local matter of one specific city that can be different from the others. And I know that WHO is trying to align that, that we also had an attempt for the Global Compact on migration, and that, but in practice that is still hampering. And then I think we have bordering problems then, that it's the responsibility is put towards the next country when migrants are continue in the migration.
Thank you, Inez, and thank you to all the speakers. Unfortunately, we've come to the end of this discussion, and we could easily carry on any one of these little topics for another hour each, I think. I think just to round up, so I'll just come back to each of you for just any final thoughts that you have. One question that we haven't answered from the audience is what do you think is the worst impact of COVID-19 related changes on GBV and migrant populations? If any of you have any thoughts on that, please do add that in, and any final kind of conclusions that you may have. Terry, to you first, please.
Okay, so I think obviously an increase in every problem that exists for migrants is happening with COVID, and then you have it being used to justify further xenophobia and exclusion. What I liked about the Lancet we worked on together was that it emphasized the incredible resilience of migrants and how much healthier they tend to be than general populations. So I want to be a little bit hopeful here. We are in New York vaccinating anybody who comes in when we have the vaccine, and many of those are undocumented people. I think there's plenty of ways to do this. So I think we just need to, as I keep saying, get a lot more specific and strategic. And thank you. I've really enjoyed everybody's remarks and learned.
Thank you, Terry. Ligia?
There we are. Yeah, I think the problems that we discussed here today, they are not new to these populations. They were there, but they seem to have been aggravated by this crisis. And the responses to these problems are also affected by the crisis and the preventative measures for COVID. As many of the panelists were talking today, we need to think about a high-level response, as Joseph put in, but making sure that they are implemented, and try to also look, listen to the voices of people on the ground with approaches that are based on their actual needs, more in the imagination that we might have of what they need or how to prevent situations of abuse and exploitation. In terms of the worst impact of COVID for this population, I think it has to do with social exclusion. So we were talking about gender-based violence that tends to be made worse, but the impact on livelihood, economic survival, it comes together with that. It is a lot of adversities that reach this population at this time. So, but I do think that there is a lot being done at the moment, and I am hopeful that we will be able to target some of these issues.
Thank you, Ligia. Inez, any final thoughts?
Yes, well, I think for the worst impact of COVID, I think regarding this matter for migrants is that with this public health crisis, we have a prioritization of people who are the priority, and then people who are a bit less a priority, and people who are not even considered as human beings anymore. And I think that often in what we see now today, migrants are put in that category of not to be cared for, to be locked up. We don't see them, we don't give them a voice, we try to ignore them, so we can focus on the priority people. So that is something that is really hard to see, I think. On the other hand, I think, and that's more the positive side, I think that more and more people are, although you see a lot of people getting more depressed and have less energy to fight, that they're also like a movement of solidarity, that we all have to fight against this. And also in the case of victims then of sexual and gender-based violence, that any victim of crime should have the same kind of protection and the same kind of care. And that's something that I'm positive about, that we can strengthen that part due to COVID as well.
Thank you very much. And Joseph?
Thank you. So I agree with all the points about the pandemic exacerbating and exacerbating already a bad situation and some of the pluses and minuses that this brings. One thing which I had on my list, which we haven't reflected on, is sort of look beyond health and look beyond sort of response of one country and look at some cross-border cooperation, right? Cross-border cooperation for law enforcement, for investigations and prosecution of perpetrators. And I think this is also taking it away from the victims and putting the burden on them. And what I would like to see is really a bit of focus shifted towards really prosecution of the perpetrators. And I think this is an important thing which perhaps once COVID is over and we kind of can refocus and kind of think again about this agenda, I think this is something that we could look at bolstering the capacity of law enforcement across our region, at least, because migration is inter-regional, inter-country. It's not just one country. And I think when it comes to this issue, we need to also look at that.
Thank you. And thank you again to all the speakers for such wonderful, insightful talks and answering my complicated questions at times. Thank you very much to the organizing team as well, especially Lucy Singh, who put this event together, Imogen Backelman, who did the comms and set things up, and others in the organizing team, Miriam Orchard, Bernadette Kumar. The recordings will be available on YouTube, and I think there'll be a link on the Institute for Global Health, the UCL Institute for Global Health website. So if you'd like to check anything again, please go there. Thank you very much. We are 3 minutes over, but thanks again to all the speakers and all the participants.
Thank you.
Bye-bye.
Bye-bye.
Bye.
Thank you very much. Bye-bye.
Thank you. Bye.
Take care.